Does any therapy improve the beta cell function? It's a $1 million question. And to answer this, Dr. Ganapathy Bantwal, Professor of Endocrinology from St. John's Medical College, Bangalore, is going to address us on this burning issue. And I request Dr. Selva Kumaran to present. Selva Kumaran. I request Dr. Selva Kumaran to present this memento and welcome him on the stage.
Any therapy prevent beta cell failure. So before I start, let me thank Dr. Krishna and his team for inviting me to speak on this occasion. Now, as you know, insulin resistance is one of the major pathophysiological feature of diabetes, but in type 2 diabetes, you don't develop hyperglycemia until there is a beta cell failure. In fact, beta cell dysfunction is associated with worsening of the glycemic control and treatment failure, and hence it's very important to recover or preserve the functional beta cell mass in the management of type 2 diabetes. Some facts about beta cell. It constitutes about 1 to 2% of the pancreatic mass, 1 gram of weight. In adults, you contain around 200 international units or 8 milligram of insulin. You have a central core of beta cells surrounded by alpha cells. 70 to 80% of the islets comprised by around beta cells, 15 to 20 glucagon, 5% is somatostatin producing cells. The blood flow is from the center to the periphery. That's why we say it's trophic to the alpha cells also, the insulin producing, the beta cells. You can see insulin resistance increases first, but then there is a compensatory increase in the insulin, and hence you don't find hyperglycemia. But the moment the hyperglycemia, the beta cell starts dysfunctioning, when the level comes down, then you actually develop hyperglycemia, or the diagnosis of type 2 diabetes happens. So what is the lesson learned is, you should have a defect in the beta cells only then, except in cases of extreme insulin resistance. Though the secretion is okay, even then you may find hyperglycemia. These are rare. These are the other ominous octet, but we will be concentrating on only the beta cell. So in type 2, this is from Peter Butler's study, what they found was in type 2 diabetes, the islets are fewer in number and functionally abnormal. And you can see this is in a normal diabetes. As you become IFG, there's a 50% reduction, and in type 2 diabetes, it's around 63% reduction. Normally in endocrinology, we say 90% should be destroyed, only then you get hyperglycemia. Any endocrine dysfunction happens when more than 80 to 90% of the cells are destroyed. Whereas here, 50 to 60% itself, you get over diabetes because they are dysfunctional. Though the mass has come down, they have become more dysfunctional because of the hyperglycemia. So this is a working model, reduced beta cell mass, there is a reduced insulin pulsatility. This is one of the first features of development of type 2 diabetes. There is an alpha cell dysfunction because of the reduced insulin pulsatility, reduced glucose uptake, reduced insulin signaling. All these things leads to hyperglycemia. So this is the insulin sensitivity and secretion relationship. We call this as the disposition index. So what you see is, if you are in this position, this is, if you come this side, the sensitivity. For that particular sensitivity, you secrete a particular amount of insulin. So it's a constant. Now from here, if the sensitivity comes down, that is, the resistance is increasing, what does the body do? It will compensate by producing more insulin. So resistance has increased, body produces more insulin, and hence we are able to compensate. This is a hyperbolic curve. But sometimes what you find is, the resistance increased, but the body is not producing the same amount of insulin secretion. This is when you are going to the left hand side, that means you develop type 2 diabetes. Now what is the lesson learned from this is, because of this hyperbolic curve, we used to say if you have had a normal glucose this year, next year you won't get it. No. Anytime, say you got some stress, say an infection, suddenly it can come down. So because of this hyperbolic curve, you can deviate to the left suddenly. So it's not mandatory. I was normal last time, my sugars were okay last year, and I have to be normal. No, not possible. It is still possible to get hyperglycemia within the next 6 months or 9 months because of some factors. So how do they adapt to changing sensitivity? You can So the upper side you see neogenesis, replication, hypertrophy, that maintains the beta cell mass, and the lower side apoptosis and necrosis. That's a balance later on after 5 years of age. Secondly, you also find that not everyone deteriorates at the same thing. You were normal, suddenly you become diabetic, or you went into the stages of IGT, IFG, and then you became diabetic. So what contributes to this progressive beta cell loss of beta cell function and mass? Glucotoxicity, lipotoxicity, it could be because of inflammatory cytokines and leptin, or islet cell amyloid. So what does glucotoxicity do? Chronic hyperglycemia induces potentially irreversible beta cell damage. There's a reduced insulin gene expression, and when you have a very high glucose level, they produce apoptosis. What is the mechanism? Hyperglycemia sends more of pro-apoptotic signals. There is ER stress, increase in cytosolic calcium, and produces reactive oxygen species. So you can see this photographs. So at a lower level, you find less number of these nucleated cells, which indicates less beta cell death. At 11.1 millimole, you see more. At 33, you see more. So as the hyperglycemia increases, there is more beta cell death. Lipotoxicity, this is actually glucolipotoxicity. You will not get purely lipotoxicity. You should have a hyperglycemia, only then you get the lipotoxicity. So when you have an excess free fatty acids, they are pro-apoptotic. Saturated ones are the ones which are highly toxic. Monounsaturated fatty acids like oleate are protective. So they produce these effects via ceramide mitochondrial pro-apoptotic pathways. Now, as I told you, you require to have a hyperglycemia. So when you have hyperglycemia, the lower end, the red side, going in for glycolysis, enter into the mitochondria. So it will enter into the citrate pathway. We have so much hyperglycemia, there is a block in the conversion of acetyl-CoA to fatty acid synthesis. So the malonyl-CoA inhibits CPT1, thereby preventing the entry of long chain fatty acids. You can see here. So there is an accumulation of fatty acyl-CoA in the cytosol, and this leads to toxicity. Now, how does pro-inflammatory cytokine and leptin produce? They can modulate the beta cell function. They induce ROS, reactive oxygen species, and interleukin-1, which are toxic. They transcript more number of nuclear factor kappa B, which play a critical role in mediating inflammatory response. So this is the adipoinsular axis. So you can see that when you have more adipocytes, the lower one, you have more of leptin, TNF alpha, resistin, which will have a negative regulation of the beta cells. And when you have less of fat, you have more of adiponectin, visfatin, IGF-1, which have a protective or a positive regulation on the pancreatic beta cells. IAPP mainly in animal models, in humans it may not be a etiological factor. So reduced beta cell mass will lead to further beta cell mass, further ER stress, further dysfunction, and finally lead to diabetes. So beta cell dysfunction in a nutshell mechanism: high glucose per se, lipotoxicity, cytokines, hypoxia, mutations, IAPP, all these things contributing to ER stress, and you find that there is less protein synthesis. So this is the classical natural type 2 diabetes course. So you had normal glucose tolerance, you have some susceptible beta cell, then beta cell failure because of some factors. You can see here beta cell mass reduced at the by around 40% at the level of the pre-diabetes, and when you develop type 2 diabetes, you already have had lowered the beta cell mass by around 60%, and I told you the reason why this happens. Now, can we reverse? So clinical intervention to preserve or rejuvenate beta cells. There are some short-term intensive insulin therapy in newly diagnosed type 2 diabetes, modulation of the beta cell ATP sensitive potassium channel, or anti-apoptotic drugs. What about short-term? So this is one study. All patients received continuous subcutaneous insulin infusion. After 6 months, you find that 9 have gone in for remission. Another study, 16 subjects treated initially 2 to 3 weeks with insulin. At 1 year, 7 maintained good glycemia on diet therapy alone. 8 required OHS, 1 required insulin therapy. Now, this is one of the landmark studies, RCT, done by Wang et al., published in the Lancet. He there were 3 groups. One received continuous subcutaneous insulin, second one received basal bolus regimen, and the third one on OADs. So what you can find here is the one who receives insulin infusions, that is a continuous insulin pump, and the multiple dose insulin, you find that the remission was more in them, 51 and 49%, compared with those on OHS, it was around 26%. And then there was a meta-analysis of this, and what they found was incidence of drug-free remission was around 66.2% after 3 months of follow-up, 60% after 6 months, and around 45% after 12 months, and 42% at 24 months. And then there was a review by David Owens. So what he told was, it does preserve or regenerate beta cells. You require to give at least 2 to 3 weeks of intensive therapy with continuous subcutaneous insulin or multiple daily dose of insulin. The improvement of beta cell function, it mainly restores the first phase insulin secretion, and you also find that the pro-insulin level comes down, because pro-insulin, normally 95% is actual insulin, 5% is pro-insulin. When the beta cell is stressed, you have more of pro-insulin, that's why the ratio goes up. So by giving this, the pro-insulin ratio comes down, would lead to remission at least for some period of time. So what is the take on this? On balance, intensive insulin blood glucose control is little to no beta cell protective effect after a long time. Initially, yes, it's very useful. It definitely has a role for prevention of microvascular and possibly macrovascular complication. The second one, can we modulate the beta cell potassium ATP channels? So it has previously been spoken, glucose enters the beta cell via the glucose transporter 2, gets metabolized, glycolysis, ATP will increase, which will close the potassium channel, which will lead to depolarization. This in turn will open the calcium channel, and then you find that more insulin is released. Now how about blocking this? So compounds which open the potassium channels, so sulfonylureas etc. close it, glucose also close it. How about opening it? Yeah, they hyperpolarize the beta cell, prevent insulin release even in the presence of glucose. Most potent is diazoxide. We use this in patients with insulinoma. Newer ones are there, the numbered ones, NN414. Preserves insulin stores, preserves pulsatile insulin secretion, protects beta cells from chronic overstimulation. Mechanism probably via beta cell rest. It could also be anti-apoptotic by blocking glucose-induced calcium increase inhibiting apoptosis. So what are the implications? May provide a strategy to protect beta cell and to improve islet function. Short-acting secretagogue preferred, less exposure to pro-apoptotic stimuli during protracted treatments with these agents. Then I told about anti-apoptotic drugs which reduce the apoptosis, leptin, aminoguanidine, glitazones, and drug acting on the incretin axis. Leptin, animal models only, but no utility in humans. Aminoguanidine, yes, they found once again in animal body models, not so effective in humans. Glitazones, yes, this was one of the most durable ones. How do we indirectly know that this drug is prevents beta cell destruction? Is you find they are more durable. You find that the doses of the other medications are coming down. So glitazones were supposed to have the highest durability. They act at the level of the nuclear receptor. This was the ADOPT study where they found that initially, yes, it did not work so well, but at the end of 5-6 years you find that they were the most durable. The next one was metformin, and the least was sulfonylurea, because sulfonylurea will stimulate more of insulin, it will whip a tired horse. So it produces what is known as a fatty acid steal phenomenon. So large fat cells are more insulin resistant. You produce small fatty cells which are more insulin sensitive. So this is known as a fatty acid steal phenomenon. So overall, what do? Reduce lipotoxicity, glucotoxicity, reduce TNF alpha, increase the adiponectin. Via this, they increase the beta cell mass, beta cell proliferation, decrease apoptosis, increase insulin synthesis. So you can see with rosiglitazone at 12 weeks and 16 weeks, you find they prevent beta cell loss. So glitazones, the best what we've had, a lot could be learned about beta cell protection from finding out exactly how the TZDs work. But then the only controversy is offshoot effects, is acting at the genetic levels, but other offshoot effects, osteoporosis, the latest scare is the bladder cancer. So many have lost interest in this molecule now. Now coming to the last one, the incretin, diabetes in the incretin system. You all know this, you have heard. So what are the effects? Alpha, beta, delta cell express receptors for GLP-1. In the beta cell, glucose stimulated insulin release. This is also an secretagogue, only thing is this is glucose dependent, whereas others are not glucose dependent. So 20% of the alpha cells also express GLP-1 receptor, and they produce, because of this effect, it has a glucagon suppression effect. So when the glucose levels are high, the glucagon gets suppressed. When the glucose levels are low, the glucagon actually will improve. So it is a useful phenomenon. And in the delta cell, they stimulate the release of somatostatin. So this was in the human in vitro studies. You find that when you give GLP, you find they have preserved the human islet cell morphology and functions. DPP-4 also has a similar effect. This is in mice studies. And there are clinical evidences, GLP-1 exist in various studies are there in short term and long term studies. So what are the take homes from incretin? These are a disappointment in humans, since in rodents it showed a significant increase in the beta cell mass. The studies do show a continued improvement in the beta cell function when on the drug. How long does the treatment benefit last, and will it bring a durability that exceeds what we currently have and is clinically meaningful is a $1 million question. Especially the GLP-1 analogs, the only problem is you will have to continue to give. The moment you stop, the effect actually goes up. So the duration of therapy is indefinite. Lastly, before I end, I thought there was some studies of interleukin 1 receptor antagonist in type 2 diabetes. It was used in type 1. Type 2 also they found it was useful in the first study, which came in the New England Journal. Then long term studies, these were the short term studies. Long term studies found they were not beneficial. So this is also not useful. In conclusion, beta cells play a vital role in glucose homeostasis. Type 2 diabetes is associated with beta cell dysfunction. Once this dysfunction happens, the hyperglycemia develops. Glucotoxicity, lipotoxicity, apoptosis, incretin defect do play an important role in the development of this. To some extent, it is reversible in some of the patients group if the above etiologies are adequately addressed. Thank you for patient hearing.
Thank you very much, sir. Let me now request Dr. Nageshwaran to present this photograph and thank the speaker. No questions. No questions. We'll move on to the next topic, next lecture by Dr. Krishnaji Seshadri. He is going to talk to us on origins of diabetes. Dr. Krishna Seshadri is known to all of us. He is the professor of endocrinology in Sri Ramachandra Medical College and he is a prestigious friend for every one of us here. All of us know him, or he has interacted with all of us. We are proud to be associated with him, Dr. Krishna Seshadri. I request Dr. Prasad to present this memento and welcome him on the stage.